Today, we're covering one of the most high-stakes, high-pressure neuro situations you'll ever face at the bedside: seizures, specifically epilepsy and status epilepticus. This is where your critical thinking meets your rapid response skills. And trust me, your patients need you alert, fast, and calm. Let's start with the basics. What is a seizure? A seizure is a sudden, abnormal burst of electrical activity in the brain that temporarily disturbs brain function. That electrical storm can show up in all kinds of ways, from full-body convulsions to brief staring spells. It all depends on what part of the brain is involved. Now, not everyone who has a seizure has epilepsy, but epilepsy is when someone has 2 or more unprovoked seizures. That's the official diagnosis. Etiology. So why do seizures happen? Let me give you a few common causes. Cerebrovascular disease, think strokes or bleeds. Hypoxemia, lack of oxygen to the brain. Fever, especially in kids, febrile seizures. Head injury, hypertension. CNS infections, meningitis, encephalitis. Brain tumors. Drug and alcohol withdrawal. Electrolyte imbalances, low sodium or calcium, for example. I always say, if the brain's under attack, it'll let you know. And seizures are its alarm system. Types of seizures. Let's break this down. There are 2 big categories: generalized seizures and focal or partial seizures. 1. Generalized seizures. These affect both hemispheres of the brain. The most dramatic type is the tonic-clonic seizure, formerly called grand mal. Here's the play-by-play. Tonic phase, body stiffens. Clonic phase, rhythmic jerking. Then comes the postictal state. They're confused, sleepy, and may not remember what happened. Other generalized types include absent seizures, mostly in children, brief staring episodes. Atonic, sudden loss of muscle tone. They drop to the ground. Myoclonic, quick, sudden jerks of a muscle or muscle group. Focal partial seizures. These start in one area of the brain. They may or may not affect consciousness. Simple focal, no loss of consciousness, but odd sensations or movements. Complex focal, altered awareness, possibly automatisms like lip smacking or picking at clothes. Some seizures start focal and spread. That's called secondary generalization. What does a seizure look like? You'll want to know if the patient has an aura, a sensory warning that a seizure's about to happen. It could be a smell, a feeling, a visual disturbance. Sometimes this gives clues to the seizure's origin. For instance, a flashing light might mean the occipital lobe is involved. During the seizure, observe and document. What movements were seen? How long did it last? Were both sides of the body involved? Was there a loss of consciousness? What was their postictal state like? Nursing priorities. Let's talk nursing. When someone's having a seizure, 1. Protect their airway. Turn them to the side if possible. 2. Don't put anything in their mouth. No tongue blades, nothing. That's outdated and dangerous. 3. Pad the bed rails if you know they're at risk. 4. Stay with them. Stay calm. Afterward, assess neurostatus and reorient them. You document start and end time, what you saw, how long it lasted, what interventions were done, and how they responded. Medications. Let's hit the common anticonvulsants. I'll mention a few, but remember, we match the med to the seizure type and the patient's profile. Phenytoin, Dilantin, watch for gingival hyperplasia, rash, and visual problems. Valproate, Depakote, nausea, tremor, weight gain, hepatotoxicity. Carbamazepine, Tegretol, dizziness, double vision, blood dyscrasias. Lamotrigine, Lamictal, major risk, Stevens-Johnson syndrome. Topiramate, weight loss, confusion. Phenobarbital, sedation, rash. Levetiracetam, Keppra, fatigue, sleepiness, irritability. Blood levels matter. Know your therapeutic ranges and monitor for toxicity. And yes, patients need to take these every day. No skipping, no cold turkey stops. That's how status epilepticus starts. Nursing diagnoses. You better believe the NCLEX loves these. Risk for injury, fear related to potential seizure, ineffective coping. Knowledge deficit about the condition or meds. Patient education. Let's talk teaching. Your patients need to know. Take meds exactly as prescribed. Don't just stop meds because they feel better. Know their triggers: stress, sleep loss, alcohol, flashing lights. Use stress management. Maintain consistent sleep and meal schedules. No alcohol, no driving unless cleared. Wear a medical alert bracelet. Keep a seizure diary to track patterns. Tell every provider what meds they're on. Lots of interactions out there on the adventures. They may also benefit from support groups or epilepsy foundations, especially for help with employment and social support. Status epilepticus. This is the emergency. A seizure lasting more than 5 minutes, or a series of seizures with no recovery in between. It's not just dramatic, it's life-threatening. The brain gets less oxygen, muscles keep contracting, and the metabolic demand skyrockets. You can end up with brain damage, cerebral edema, or even death. Common causes: missed meds, infection or fever, illness or metabolic changes, alcohol withdrawal. Treatment priorities: 1. Stop the seizure. That's number 1. IV lorazepam, Ativan, or diazepam Valium is given immediately. Fosphenytoin, phenobarbital, or other maintenance meds follow. 2. Airway and oxygen, intubation if needed. 3. IV access, labs, glucose check. Treat hypoglycemia if that's the cause. 4. Continuous monitoring, EEG, vitals, neuro checks. Nurses monitor closely for respiratory depression, hypotension, or postictal swelling. Keep suction equipment ready. Turn them on their side. Protect their IV site. It can dislodge during a seizure. You've got to think ahead. Also, long-term anticonvulsant use can cause bone disease. These patients are at risk for fractures during a fall or even from the seizure itself. Wrap up. So what do we want from our patients with epilepsy? No injuries, decreased fear, good seizure control, medication compliance, a safe, informed life outside the hospital. And what do we want from you? That when a seizure happens, you don't panic. You protect, observe, document, and treat because you knew exactly what to do.